So we're just going to talk about the clinician perspective a little bit to guide us all. So we're going to talk about nutritional considerations for people on AOMs, the reason you came, right? So, nutritional considerations for people on AOMs, and where are we now? Like, what do we know now? Because, the reality is we don't have a whole lot of data. And what I would, hopefully, my number one thing I would like you to leave here today with, aside from a few tips and tricks if you're, delivering clinical care, is that we need to all participate in much more research. We need much more, even real-world research on the way patients are interacting with their food and with their environment as it relates to taking anti-obesity medications. So as Harold mentioned, Dr. Angela Fitch, I'm the immediate past president of the BC Medicine Association, and I did primary care for 10 years before getting into obesity treatment. Was board certified in 2012. The first year there was a board certification for obesity, and I've been doing obesity management, for quite some time. And again, I just really, we see a lot of this in our practice. You guys probably see a lot of this in your practice as well, as far as trying to learn some nutrition on the go. I do not have any specialized nutritional training necessarily. It's been all sort of self-training over the years by wonderful dietitians like Linda. And again, the other thing I would like to leave you with before you go is that if you have access to a dietitian, if your patients have access to a dietitian, I can't underestimate it enough how important it is to have our patients meeting with a dietitian. And many times patients will tell you, I do not want to meet with a dietitian. How many dietitians are out there? You got a lot of dietitians? Yeah, I feel bad for you. Like, no one wants to meet with you. It's almost as bad as the dentist. Because it's like, but our dietitians are very, I think one of the things I hear from patients is that, well, when I go to the dietitian, I want them to tell me what to eat. And the dietitians tell me, well, we can't tell people what to eat because they won't eat what we tell them to eat. And so, again, it's like this dichotomy, right? Because people are like, just tell me what to eat. And we're like, well, we can't really do that because if we did that, you wouldn't do it anyway. So we need to work together, right, to optimize your nutritional quality. And that's what we're going to talk about a little bit today. Here are my disclosures. I do a fair amount of consulting for various people in this space. So this is just our current nutritional recommendations for our bariatric surgery patients. So we have I just wanted to level set this with, this is from the ASMBS, right? This is the guidelines that have been put out by the ASMBS and with us, multiple of us, many of you maybe have helped to write these guidelines. But the idea is that we have a lot of data on our surgery patients. So why would we not sort of use that data to inform, what we're talking about with our medical patients today? Because now with our newer agents, we are a lot of times getting a very similar, outcome from a weight loss perspective, right? From an appetite suppression, from a desire to eat certain foods relative to the treatment, right? And so again, if we have these data, why not use them to inform what we're doing? And so again, you can see within these guidelines, right? These are several different guidelines across different societies. But the idea is to prioritize protein, right? To minimize processed carbohydrates, right? Or processed foods in general. We'll talk about that in a little bit. And then to supplement with vitamins and micronutrients, right? We supplement our patients. We currently don't have any recommendations to necessarily supplement our patients that are taking AOMs. But I certainly have that conversation with patients every day in my clinic that are going on medication for obesity is, get an idea, get a 24-hour recall even of what they eat. Do they have specific eating tendencies? Are they vegetarian? Are they vegan? How are they going to prioritize their protein? And then how are they going to prioritize their micronutrients? And if they're not, really, encourage them to use a high-quality multivitamin because that's what we encourage, for our patients who have surgery as well. And then laboratory monitoring of micronutrients. We do this quite regularly in our surgery patients, right? But we don't have current guidelines that we need to do that. But just because we don't have current guidelines, and we will very soon, I will sort of level set everything to say that we are currently writing some guidelines around, what we should be doing in this field. So be on the outlook of that, in the next 6 to 9 months. But the point is that in the meantime, it never hurts to talk to your patient and figure out if they're having any signs and symptoms of micronutrient deficiency. And it certainly also never hurts to check some labs on a routine basis to try to see, to make sure. And again, it depends on what that history is you're getting from a patient. So again, I think the question of, should we follow similar guidelines with AOMs that produce similar weight loss outcomes as surgery? And I do think the answer to that is yes, right? If your patient is going to get a very similar outcome to what you see with bariatric surgery, then I think, it is something we should try to think about. And at a minimum, if you're worried about it as a clinician and you don't know what to do, to follow the guidelines that we have before us, for our surgery patients. These are just some general nutrition principles in obesity treatment for you to take home. This was the work of us at the OMA, Dr. Lily Alexander and Harold and myself, in terms of writing these clinical practice statements that we have in Obesity Pillars. Obesity Pillars is the journal of the Obesity Medicine Association, and all of this is open access to you. So all of you have access to Obesity Pillars. It's an open access journal. There's no need for a membership or a fee or anything, but we have a lot of clinical practice statements written in there on each of these topics, on nutrition, on physical activity, on other clinical approaches, to treating the patient with obesity. And these are just some of our top 10 takeaway messages, as it relates to, treating patients from a nutritional perspective. And it talks about things like the Mediterranean diet, like the ketogenic diet, like the DASH diet. Not to say that those are preferred necessarily eating patterns, but those are some dietary patterns that have data behind them to support effective weight management. And if your patient is inclined to follow one of those plans, and that's what Harold talked about in the beginning, you really have to meet the patient where they're at. And if they're inclined, because it's easier for them to live into a low carbohydrate lifestyle, right? If it's easier for them to say, I just don't eat that, right? As they're dealing with the tray of muffins, out at the breakfast counter, if that is what is easier for them to manage, then help and support them, in that journey, but also make sure they're getting enough nutrients. And on the other side of it as well, make sure they're not thinking of that in a overly distorted or disordered manner, right? The idea that a muffin is bad for you is not something that we want to promote, but also at the same time, the idea that something like, for example, Doritos has any sort of healthful nutrition in it is probably a misnomer, right? But again, we don't want to say to someone that's not something that you ever eat, to develop some of this good and bad food sort of situation. But at the same time, we know, all of us know, and I think most of our patients know, to be honest, that some of these things that are out there for us as food are not things that are really nutritious, right, as it relates to getting nutrition into our body. So we recently wrote an article, myself, Dr. Alamandos, who is the first author on this article, as well as many of you, probably many of you in the room. There were quite a bit of us, Dr. Ard and others. Anybody else that was in the room that was involved in our article? Just so I don't forget anybody in case you're here. But again, we got together as a group of experts and said, hey, what can we say about nutrition? So again, we use this sort of 5 A's approach, which is to ask permission, assess, advise, agree, and assist, right? The idea that we should all be taking a brief nutritional assessment, right, to look at risk factors for deficiencies. Is this patient, eating, do they have a very restricted diet? I have a 13-year-old patient with severe obesity, greater than the 140th% to the 95th percentile. She would qualify for surgery. That is not the path that her family wishes to take at this point, and especially because this patient will only eat chicken nuggets, pizza, and cereal. And that is literally her diet. She has an autistic spectrum disorder. She has a lot of issues with textures and other types of foods. And again, in treating her now, we have been successful in reducing her consumption of those foods in general by treating her with an AOM. She has been very successful in losing her weight. She is a much happier child now. She interacts with me on the telemedicine in particular. Before, she would hide behind the iPad, one of those deals, I'm seeing half. The mom's trying to put it in front of her face, and she's like, no, I don't want to talk to Dr. Fitch, right? But now she sits there and talks to me, and I said, hey, can we focus on eating one vegetable a day? No. I'm like, okay, well, what about one vegetable a week? Okay. Well, what vegetable do you like? Do you think you might want to try? Okay, we got some carrots out of it, in the long end of that discussion, right? And then we figured out she likes strawberries, right? And when I was first working with her mom has had bariatric surgery. Her sister also has obesity. Her sister's quite younger. But again, I was working with mom. I go, what does she eat at school? And she goes, well, she often doesn't eat at school because she doesn't like anything except for cereal, pizza, and chicken nuggets. So unless they have one of those things at school during lunch, she's not, eating lunch. And I said, well, can we get her to take a protein shake to lunch every day? And sure enough, she does. So now she's eating less chicken nuggets, she's eating less pizza, she's eating less cereal, and she is losing weight, and she's drinking a protein shake every day for lunch, which has, some micronutrients in it, some vitamins in it that she wasn't getting before. And she's working on eating a fruit every day, which is strawberries at the moment, and eating some carrots. So we're making these small wins, right? And some people might have said in the past, I shouldn't medicate that person for her obesity because she's not eating, well enough for me to medicate her. But is it better for her to go about her life continuing to gain weight, eating these types of foods that she's sort of stuck on, without the support of that GLP-1 at the same time? Or is it better to give her that support, while she's losing some weight and while she's actually engaging in some of these physical activities and other things that she's doing? So the point of all that is to say we have to do these A's with people because, this is something that is not sort of cut and dry, and we can't just do it, everybody doesn't get it right? And it's hard for patients that are managing these things on a daily basis out in the environment. And then after the nutritional supplement, monitor treatment response, advise on recommended intakes, and as Harold really stuck home, the fluid is a specific issue, the protein, and then the fiber. So those are the three things that I think we really have to focus on, is that fluid, that protein, and that fiber. The benefits of protein intake, right? We have been recommending in obesity treatment and obesity medicine 1 to 1.5 grams protein per kilo of ideal body weight, adjusted body weight, whatever, not actual body weight, because that can get pretty high, right, if someone weighs 350 pounds. But the idea of this higher protein, and when I talk to patients or when I talk to residents or when I'm teaching something, this isn't high protein necessarily. Like, we're not talking about excessive amounts of protein because our athletes, right, have been taking in higher amounts of protein for a long time. Why would our patients with obesity who have, or as Harold mentioned, had tended to have larger muscle masses, why would they not take higher protein levels, right? It's almost like that bias and stigma around that patient with obesity has crossed over into the fact that we say, well, you should only eat 0.8 grams per kilo, which is the recommended, daily allowance of protein. And again, really sort of harping on that protein is key. And what I tell patients, if you can't get that protein, right, with, your food that you're eating, then, have some sort of protein supplementation. And whatever that looks like for you, it could be something you make yourself at home with protein powder, could be something you purchase, have available for you. But having that is not necessarily, it's better to have some protein than to have nothing at all. It increases satiety. There's some data to suggest that it can increase lean body mass retention during weight reduction, although as Harold mentioned, we don't really know. And it can also increase thermogenesis, right? There is this thermic effect of food that we forget about. And we know that protein has the highest thermic effect of food, right? And so when we eat protein, we burn more calories by eating protein. When I tell patients this, they are like amazed at well, that's good. I can eat protein and burn calories. Yeah, you can eat protein and burn calories. So again, it's one of those things that can encourage patients to stick with some of your recommendations when you give them sort of another little benefit. I also think we have to think about weight loss versus weight maintenance, and are they different? I think the future of our obesity care that we deliver and the research that we do is going to come into play, as we talk about this. Because patients may notice more acute appetite suppression when starting an anti-obesity medication therapy versus long-term. We know from some of the data that long-term on these medications, people's appetite comes back. And people think that's a bad thing. They're like, oh my gosh, my appetite's back, you need to make it go away. I'm like, no, that's a good thing because we want you eating, 3 or 4 times a day, and we want you eating planned portions of plants and protein. And again, we want you to have an appetite. We just don't want you to have an excessive appetite. And many of our patients who have been struggling with obesity for so long, they just want that appetite to go away, right? Because we've been telling them, just eat less, exercise more. And they're like, oh, if I could only just eat less, right? And then we give them a tool that allows them to eat less, and they're like, I'm not going to eat at all. right? And that's not what we want to do. We want people to get adequate nutrition at the same time they're losing weight. And patients may need to follow a more prescriptive meal plan in the beginning. We have data from the Look Ahead study and the Direct trial that show potentially greater treatment responses as without medication, right, in using meal replacements. I have always been a big fan of meal replacements in terms of giving patient that structure in order to get that protein in. If they want something in the beginning, a structured plan to do, having that structure in front of them can be helpful. You also may notice the changes in types of food that's preferred, okay? So we are doing a study right now in our clinic we're using an artificial intelligence type of food tracking tool that allows patients just to track by taking pictures, which is quite nice because patients like that. They don't have to type it all in, write it all down, write it on a piece of paper. I remember the days of paper. Who remembers the days of paper? Writing your food journal. And we still have some patients that like paper, actually. I have some patients, they come in with their long list of paper and files or printed off from MyFitnessPal, their daily intake. They want me to look at the whole thing. I'm like, oh, I don't know if I have time in 6 minutes, but I'm going to look through it and give you some ideas. But the point is these newer technologies allow patients to track, and the dietitians get a decent, within a fairly good amount of error, how much protein someone's eating, how much fiber someone's eating, in a day, and then we can make adjustments on that. So we are actually doing some research, though, also on how these types of medications actually change people's food preference, because we've heard this from patients, right? I'm sure you guys have heard this from patients. And one of my patients in particular who had binge eating disorder, which was in remission but during treatment, but had a little bit of a flare, she comes in and she says, Dr. Fitch, I had to stop that medication that you were giving me. And I said, oh, why? I thought maybe something happened. She had pancreatitis. She had something else happen. No. She said, it was not making me want to eat the foods that I wanted to eat, and that was making me sad. And so again, when she couldn't eat the food that she wanted to eat because she wanted to eat a box of donuts to make herself feel better, and that box of donuts wasn't appealing to her anymore because of the medication and the effects of those medication, that was a disconnect within her brain that she had to figure out how to handle, right? She had to figure out how to handle that dichotomy, and we did. We sent her she went back to the therapist, she started working with the therapist again, and we were able to get through that, and she was able to go back on medication. So my point of that is just to really reiterate that people's food preferences may change from these medications. That's not only GLP-1s, but also topiramate. We have some data around that. And if that's happening, make sure you're talking to patients about that, because make sure they're getting the right amount of nutrients. All right. This is what I've come up with myself. I've done this for many years. I came up with these P's because I was trying to figure out how can I do something on one hand. Harold mentioned one hand, which is 5 things, right? So I had to put it into 5 things. I had to group some things together to get down to 5, right? But this is what I tell patients when they say, what should I do, nutritionally, right? Because, again, they haven't seen Linda yet. They haven't got to my dietitians yet. I only have, 30 minutes. I've already talked about side effects and managed side effects and prescribed potentially medication to manage side effects, and I've titrated the dose, and I've made some changes. But here, they're asking me, what should I do? What should I do with my nutrition? And what I tell them is you need to have planned portions, so eating regularly throughout the day. Don't skip meals, right? Planned portions of plants and protein. So when you sit down to eat, tell yourself, am I eating a protein? And educate people a little bit what a protein is, right? Eggs, meat, beans, etc. Or dairy. Am I eating a plant? Vegetable, fruit, whole grain, right? And if you're not eating a plant and a protein, figure out how you can get one of those in there, right? I myself went through the airport once in, I think it was Denver, and I was like, I need a voodoo donut. Mostly I needed coffee, but I was like, oh, I can stop at coffee and get it at the voodoo donut, because anybody had a voodoo donut? They're quite delicious. So anyway, but I'm like, I'm going to get a voodoo donut, right? And so I'm saying to myself, oh, I'm not following my little guidelines, right? I didn't have a plant. Well, maybe there was a plant in the donut at one point in time, but, I didn't have a protein, right? So what did I do? I went, after instead of having the whole donut, which they're very large, you don't really need a whole donut, I eat kind of half the donut, throw the other half away in the garbage, because I'm not opposed to that, right? I don't need the whole donut. And I stopped later on at one of the little stores and got one of these farmer's fridge things, right? Full of my chia pudding with berries on top, right? And nuts. So now I had my plant, my protein, and I had a little bit of donut. So again, the idea is not to demonize certain foods, but to try to help people supplement that with these plants and protein. And then the last P's are power for strength training. We got to do some strength training. I see Dr. Tinsley in the audience, so we can go see him later. He can teach us how to do that. And then pillow, and then pause, right? So people need good sleep, and they need to pause, meaning from a stress reduction, from a not eating in the night, not necessarily intermittent fasting, but, the idea we shouldn't really, from a circadian rhythm, be eating in the night. So trying to sort of manage that and give patients these tips, I think, is key.